Thank you so much. First, let me thank the week. Very grateful for the opportunity to address the group here. In general, I think the media plays an even more critical role today than ever before in making sure that our consumers have the right information, timely information, credible information. I personally led a hospital and a health system through COVID. We realized how important a role media plays. So thank you, especially grateful to the V for having me here. I realize that I'm standing between you and lunch, so I'll try to make this quick. Our lawyers like to get paid, and they bill by the hour, so this is a disclaimer. I'm discussing things that are general observations regarding healthcare and where I think it is going. This is not intended to be any investment or other advice. So I'll start with an introduction to Apollo, and then I'll quickly move on to how we think about where healthcare is headed to and how we are planning for healthcare delivery for the next 2 decades. Keep in mind, I'm very new to Apollo. I've been in with Apollo in a leadership role for about 6 months. This is work that is done by others and with tremendous vision. If you look at where Apollo is today, it's one of the largest healthcare systems. We have about 73 hospitals spread out across the country. And it's truly a national footprint, right? Hospitals in Guwahati all the way down to Kochi. Hospital in Kolkata Kolkata to Ahmedabad. It is truly the length and breadth of the country. We combine that with a huge footprint, both on the retail pharmacy side as well as clinics. There are over 400 clinics that cater to various types of chronic disease management, and I'll touch on that a little bit. And over 6,000 pharmacies. I'm sure most of you have used an Apollo pharmacy at some point or the other. There are some other small group companies that are in there that includes home care and other offerings. But you can see across the board, it is a broad swath. It is a complete offering of healthcare services. In the US, there is a saying, cradle to grave. I try not to use that here, but it's truly an end-to-end healthcare provider for our customers. What is truly amazing to me is that all of this was built in about 35 to 40 years. It was through the vision of our chairman, Dr. Pratap Reddy, who brought private healthcare to this country and has now scaled it up to this massive enterprise. You know, during multiple conversations earlier today, we heard about meaning and purpose, right? To build something like this, clearly you need hard work, you need vision, you need tenacity, but you truly need meaning and purpose. And every time I hear the chairman talk about Apollo, he will go back to that one person, one patient that he took care of. He's a cardiologist. He returned from the US. He was practicing in India, based out of Chennai, when he had a young patient, some early 30s, but had bad coronary vascular disease. And he was trying to get this patient over to the US, to Dr. Denton Cooley, for a coronary revascularization procedure. The patient couldn't afford it, was trying to raise the funds, and in the middle of that passed away, right? And that has impacted him so much that the chairman still remembers the details. I think this goes back to having true meaning and purpose. And his goal was to make sure that world-class care is always available to every Indian. This is a very busy slide. It's a little bit more of a detail of what Apollo is. But I show this because I think it captures the essence of what we do. That central circle there says value-based and outcomes-driven care. And that is important because at its core, Apollo has been about patients. It has always placed the patient and the patient's requirements at the center of everything that it does. To the right of that, you see this massive infrastructure that is behind this organization that lets it deliver on that promise. It is an extensive supply chain network. It is an extensive combination of data, people, and expertise to make sure that we have the right clinical outcomes and that we are constantly monitoring quality. I would say it's been a pioneer for quality. The Patient Safety Conference, which will be here in Delhi next year, is where the best of minds in patient care and quality come together. This year, the start of this fiscal year, we rolled out Zero Harm, a commitment to high reliability framework and zero harm to every patient. A very high bar and aspirational goal, one of the first hospital systems to do that. And on the left, to your left, you see all of these little offerings that we have. And to their credit, Apollo was one of the first organizations that realized that at some point, patients will not want to have a single format to deliver care. Not everybody is going to see the hospital to see a patient for their blood sugar control and for chest pain. So all of these formats, Apollo Cradle for women's care, sugar clinics for diabetes care, is truly one of the first multi-format care models that has evolved over time. And I think this is where healthcare is progressing to. So I started the presentation talking about pioneers with purpose, and at the core of Apollo has been this spirit to pioneer and to innovate. And I've given you a few examples here. I can tell you that there are a ton more. I've just selected a few. A long time back, the chairman and Apollo were instrumental in changing the law and getting the regulations written so that solid organ transplants could be done in this country. Today, over 26,000 solid organ transplants have been done at Apollo, and it's the largest organ transplant center on the planet. This has not been easy. It has had a lot of ups and downs, but it's truly the ultimate gift of life, the gift of hope to patients who otherwise would die waiting for an organ. In the mid-70s, and there's a poster that sits outside the chairman's office that says Master Health Checkup. I think it was done in 1974. Master Health Checkup was supposed to be a comprehensive preventative health check. Today we heard the Honorable Union Minister speak about preventive proactive care. This started in the 1970s, and the chairman was a pioneer in trying to predict and be proactive with one's healthcare. Today, our offering in preventive health, which is branded Pro Health, we're trying to push this through our corporate channels, through direct to consumer, but also through every interaction that we have with a patient or their family member to make sure that our customers have a risk-based assessment and are proactive regarding their health. I was going to talk a little bit about technology, but Siddharth stole all my stuff about AI. But across medical technology, including information technology and AI, Apollo has been a pioneer. Today, there is the only proton beam therapy in Southeast Asia is in Chennai, and it gives the hope of cure to many, many patients who otherwise would either not have a curable cancer or would have horrible side effects of radiation through other modalities of care. Right here in Delhi at our Indraprastha Hospital, you saw the ZapX. Again, first of its kind, an extremely precise instrument to treat tumors in the brain. The first robotic surgery was instituted at Apollo, and we continue to do one of the largest numbers of robotic surgery across different organ systems. So it has always been a pioneering spirit, and you can see that history has been mostly based on investments in technology, skills, and the teams to deliver on that care. But what has brought us here may not be what takes us to the next generation. So where do we go from here? What is a framework for us to think about where healthcare is going for the next decade or more, right? We heard a lot about technology. We heard about robotics. We heard about artificial intelligence, other technological innovations like drug discovery using AI. But in the end, healthcare is about people taking care of people, right? And where healthcare is going will be determined by the consumers and what happens to them. So my sense, and we heard about this from the Union Minister, the commitment to rehabilitation and care for older citizens, the commitment to healthcare coverage for our older population. We've heard this theme consistently through all presentations, because one of the things that is happening globally on the planet, And I have my colleague, Dr. Jamie Abraham, who's an oncologist at the Cleveland Clinic in the US. We see this in the Middle East, in parts of Europe. The planet is aging. The planet has aged substantially, as I will show you, in our lifetime, and it'll continue to accelerate during our lifetime. This will fundamentally change some of the concepts around healthcare, because it's not the same diseases, and even when the same diseases affect our older patients, the kind of care they need is different. So I'll touch a little bit about this aging planet and its implications for healthcare policy. You've heard a lot about technology and other prisms through which we may see how healthcare will be delivered over the next several years. Before I go to that, let me just ask a question. It's a quick poll. Put up your hands if you think we are living longer. Are humans living longer? Yes, no answer. If you think yes, put your hands up. 50 years, over the past 50 years, has human lifespan increased or not? Many, many yes answers. So let's take a look at it. So for those who answered yes, the statistic that drives this answer is what is shown up here. It is what the number that we call life expectancy at birth. A child who is born in a country, how long can he expect to live on average? And if you look at the past 50 years, the improvements that have been made in life expectancy are incredible, right? In South America, about 25 years. Even in Europe, about average of 15 to 20 years. When you look at Southeast Asia, a country like Bangladesh has added 65 years to the average life expectancy at birth. So Southeast Asia and Africa have had tremendous impact on life expectancy at birth. And mind you, this life expectancy has not increased because of medicine. There's some contribution from medicine, but this has largely come from other interventions. The most important of it is infant mortality. We've made tremendous improvements in infant mortality across the planet, and that has had the biggest impact on life expectancy. Second is vaccination, public health, and sanitation. Sanitation that has eliminated cholera, plague, vaccination that has eliminated measles, polio, other diseases that would take out large segments of the population at a time. And then lastly, which was fascinating to me because the union minister also holds the agricultural portfolio, agriculture has contributed to the increase in lifespan. For all of you who are sitting here, 80% of the nitrogen atoms in your body comes from one chemical reaction. It's called the Haber-Bosch reaction, which fixes nitrogen in the air to ammonia and makes fertilizer. So all of these have actually contributed to this increase in life expectancy at birth. But here is a very interesting graph. This is for Great Britain, but you could draw this graph for pretty much any country. So let me explain this to you. On the y-axis are the percentage of people surviving at a certain age. So as you go, it is 10, 20, 30, 40 years. How many people are left? What percentage of the population is surviving at each age? And each one of those lines is a year. It starts with 1851 and it goes all the way through the 2000 to 2031. See what this graph tells you. The actual human lifespan has not changed. From 0, it's about 121 years. We have not changed that in more than a decade, but what has changed is early mortality. Avoidable mortality. You see where infant mortality takes out a lot of kids at a young age? That has improved. Today, most countries, including India, we are dealing with NCDs, non-communicable diseases, not childhood mortality. As you take out NCDs, that graph gets more or less rectangularized so that early mortality is minimized, but the entire human lifespan has not changed. Now, would that change in the next 30, 40 years? That's a different topic, it's a different talk, and it's fascinating because there are companies, entire faculty from Harvard have left their jobs and they're founding companies to increase human lifespan, but I will not get into that. So far, human lifespan has remained more or less finite. And this is actually the oldest person. She passed away in 1997, Jeanne Calment. She was French and is a best studied person, good records. So I think she lived to be about almost 122 years if you do the math. But what is even more fascinating to me as a pulmonologist is she was a smoker. She smoked for 97 years of her life. Not a heavy smoker, but she smoked a cigarette and had a glass of port wine. I'm not recommending this as a intervention, but it's a fascinating observation. So here is the healthcare implication of what I just told you, right? Keep in mind, if you were to take an average country, let's say 1900s, a lot of infant mortality, a lot of early death, average life expectancy is low. As you improve life expectancy, the dots are the NCDs. The graph becomes more and more rectangular. There is still a lot of death from trauma, but most of the death occurs in the last few decades of life. This is a phenomenon that Professor Fries and others termed compression of morbidity. What that means is that most of the illness that leads to death, most of the severe illness occurs in the last couple of decades of life. Now, this is not just a theory anymore. If you look at the Western countries in Europe, the more advanced nations, this is actually happening there. Most of the morbidity, most of the admissions occurs in the elderly patient population. So think about this, think about what is happening globally and what this means for providers, what it means for insurers and payers, what it means for government and healthcare policy. Even beyond that, think about what it means for education, how we prepare our medical students, how we prepare our allied workforce and nursing workforce. So I'll get into this a little bit because I believe the implications are significant. Something happened in 2018, so this is a year before COVID hit us. This is not due to COVID. For the first time, there were more people above the age of 65 than children under the age of 5. That has never happened before. And that trend is going to continue to increase. So by about 2050, if this trend continues, right, about 16% of the planet will be over the age of 65. So combine these two findings, a high level of morbidity in an aging population, but also a demographic that is changing globally where there are far, far more older individuals than children and young age people. This is not something that we see in India yet, but this is where we are headed to. 1 out of 5 people under the age of 25 lives in this country. And that has implications too. We will be the healthcare workforce for the planet, right? Because when you look at how each country is headed to on this trajectory of aging, there are only a few countries that are left. So by 2050, only Africa, the nations in Africa will have young individuals and a population that is not more than 15% aged. This has tremendous implications. It'll strain healthcare. It'll strain the capacity of beds. The minister talked about acute, post-acute care, rehabilitation. Those facilities will be required at scale, a workforce to take care of them. And I'm sure AI and other tools will be available, but it still may not solve the problem that is in front of us. So what are the kind of diseases that we should expect to see? This is purely my personal experience having taken care of patients now on 3 parts of the globe. Infections and sepsis are going to be a huge burden. You know, we think we have great antibiotics, we think infections are manageable, but this is going to be an entirely different spectrum of infection and sepsis that affects a vulnerable portion of our population. We have to prepare for it now. Antimicrobial stewardship needs to start today. The way we think about vulnerable populations with implants, hip implants, intravascular devices, pacemakers, and their susceptibility for infection has to change. We need more research, awareness, and management around infections and sepsis. I know there were several conversations around degenerative diseases because we don't understand them well. These are a group of diseases that appear mostly within this age group. Non-communicable diseases like strokes, complications of metabolic disease, cardiovascular disease, cancer, they will continue to present, but the way we will have to take care of an elderly patient population, let's say with stroke or suffering from an acute myocardial infarction, is going to be entirely different. The hospital requirements are going to be different. the need for post-acute care is going to be different. And that sets us up, nations, to have entire plans around rehabilitation and long-term care. I think it was a minister who spoke about the shift to nuclear families and the lack of family support. And lastly, I think it's healthcare, education, and research. Education, including those who serve, physicians, nurses. We are doing our bit today. Apollo trains a large number of nurses. We've started new fellowship programs just within the past 2 weeks, aimed at fellowships like colorectal surgery, pulmonary, diseases that we believe will have much higher incidence and prevalence in the next 2 decades. We are preparing tomorrow's workforce today. And this applies to nursing as well, which most of you are aware, globally is in severe short supply. This is from Germany, but there's similar data in the US from Derek Angus and group. What you're seeing are 3 lines, which is males, females, mortality. Age, mortality due to sepsis. You can take mortality, hospitalization, any number. Infections and severe sepsis bookend the 2 ends of life. There is neonatal sepsis, a low incidence of sepsis, and then it climbs up exponentially in the later ages of life. This is true across the planet. You can see the implications when a population ages at the rate that I indicated previously. Degenerative diseases. On the top are the different mechanisms of aging. It's oxidative stress, the way your mitochondria works, the ability of your cells to undergo a process called autophagy, which is a self-destruction, DNA methylation, which is epigenetics. Each one of these mechanisms is implicated in these degenerative diseases. Degenerative osteoarthritis, the need for orthopedic surgery. Degenerative conditions of the brain, including movement disorders, cognitive impairment, Alzheimer's. Macular degeneration leading to vision problems, COPD, heart disease, vascular disease. All of these will have a much higher incidence and are essentially disorders of aging. These are disorders of degeneration. We need funding, we need primary research, we need drug discovery, because many of them today have no cure. And when patients, geriatric patients, get admitted, those of us who are practicing physicians, I'm an intensivist, we know that the challenges are different. These patients present with frailty, they have underlying malnutrition and impaired ability to sense nutrient. They have cognitive impairment that flares up during a hospitalization, leading to episodes of delirium and confusion that can independently affect their outcome and mortality. So how we take care of patients, even how we design our facilities, needs to take all of this into account. How are we responding? Of course, we need more beds. We've seen that increase in requirement at a national level. So we are preparing, I believe the number, the publicly available number is almost 3,000 beds over the next 1.5 to 2 years. But it won't just be more beds. We have to think about how we create those beds. What diseases, what service lines will we take care of them? How do we design these hospitals? How can we create smart hospitals that allow our elderly patients to navigate through the hospitals, use the services, and not set themselves up for complications such as falls and complications of confusion. I think you heard a lot about artificial intelligence and how Apollo is investing in that, so I will not bore you with all that. Siddharth did a fantastic job. And finally, we are putting a lot of effort into preparing our workforce. Again, without a prepared workforce that is able to take care of those challenges, it'll be and this is a global issue. This is not for providers to solve. This is not for education, the education sector to solve. It is society's responsibility to figure out how are we going to take care of an aging planet for the next 20 years. I'm very interested because I'm heading towards that very soon. Long-term care, this is US data. Keep in mind that patients who have an injury, a fall and a fracture, will not just leave the hospital and go home. Elderly patients need long-term care. Care for cognitive impairment. Patients who have frailty and other complications of aging. All of this requires a continuum of care that allows our patients to rehabilitate and recover once they leave the hospital. That's all I have. Thank Thank you very much. Very grateful for your participation.